Hormone literacy is power, and when a woman understands her biochemistry, she becomes unstoppable. In today's episode, we're going to cut through the medical fog around 4 of the most misdiagnosed hormone-related conditions in women: PCOS, endometriosis, Hashimoto's thyroiditis, and perimenopause. We'll unpack how these conditions get missed, misread, or outright dismissed, and more importantly, what to do about it. The 4 most common hormonal misdiagnoses in women and what to do about them. Have you ever been told, "You're fine. Your labs look normal. It's probably just anxiety or stress"? I'm Dr. Sara Szal, and welcome to Treated, where we dive deep into the biochemistry of being a human and how conventional medicine often misses the mark. In today's episode, we're going to cut through the medical fog around 4 of the most misdiagnosed hormone-related conditions in women: PCOS, endometriosis, Hashimoto's thyroiditis, and perimenopause. We'll unpack how these conditions get missed, misread, or outright dismissed, and more importantly, what to do about it. So why this episode? Because hormone literacy is power. And when a woman understands her biochemistry, she becomes unstoppable. Number 1, PCOS, the metabolic misread. You show up to your doctor's office with fatigue, acne, difficulty with managing your weight, maybe infertility and an irregular period, and you leave with an antidepressant. You might be told your labs are normal. Maybe you just have stress or low serotonin. No, it could be polycystic ovary syndrome, PCOS. It's a highly underdiagnosed condition, especially in lean women. PCOS affects 1 in 10 women, but 70% are undiagnosed. The common symptoms include irregular or missed periods, cystic acne, fatigue, weight gain or insulin resistance, where your cells become numb to insulin, hirsutism, which is where you have increased hair growth where you don't want it, like your chin and around your breasts, mood disorders, nervous system dysregulation. Standard blood panels often miss it. So what some doctors do is they run an LH and FSH, and they tell them they look fine. The truth is you need additional testing. You need a fasting insulin, a DHEAS, free and total testosterone. PCOS is very common, and it can take years to get a correct diagnosis. It is not just an issue in the reproductive years. It causes an increased metabolic risk for women in perimenopause and menopause related to the high androgens. Most primary care doctors do not know how to diagnose it. We'll talk more about PCOS in an upcoming podcast with celebrity gynecologist Dr. Thaïs Aliabadi from Cedars-Sinai, known as Dr. A to her clients and fans. In the meantime, what can you do? Number 1, ask for these additional tests: fasting insulin, DHEAS, free and total testosterone, sometimes a 17-hydroxyprogesterone. Number 2, about 70% of women with PCOS have insulin resistance. So you might want to consider a continuous glucose monitor to help reverse insulin resistance. We now have CGMs over the counter. They no longer require a prescription. And number 3, check out my book, The Hormone Cure. Bring it to your next appointment. There's a link in the show notes. And point out the additional consideration and tests that you deserve. Number 2 is endometriosis. I think of this as the 8-year delay. Women get told, you have painful periods? That's normal. That's part of being a woman. How about birth control pills? Maybe you have irritable bowel syndrome. So these are dead ends that so many women with endometriosis hit for years, on average 8 years before diagnosis. Symptoms of endometriosis include debilitating cramping with menstruation, pain with sex, bloating, constipation, fatigue, infertility, chronic pelvic pain that doesn't match imaging. The main clue with endometriosis is that the pain is real, recurring, and it worsens with the menstrual cycles. Yet ultrasounds are often normal. Diagnosis usually requires laparoscopy. Similar to PCOS, endometriosis affects 1 in 10 women. Yet many are misdiagnosed with, oh, you just have painful periods, you have irritable bowel syndrome, you've got bladder issues like interstitial cystitis, or you have anxiety or depression. In an upcoming pod with Dr. A, we're going to dive deep into endometriosis as well as PCOS. So what do? Number 1, track your symptoms in detail. Use a symptom journal or app like Clue or Flow to log pain, location, intensity, and timing, your bowel and bladder symptoms, the cycle phase, and any flare patterns. This helps you gather objective data that a future provider can't ignore. Number 2, don't tolerate being dismissed. If you're missing out on work or life because of pain with your menstrual cycle, that is not normal. You deserve a diagnostic laparoscopy. This may require that you seek a second or third opinion, preferably from a gynecologist with endo experience, like Dr. A. Not all gynecologists are trained in identifying and excising endometriosis. So look for one who does advanced laparoscopic or robotic excision surgery, not just ablation or birth control prescriptions. And number 3, you deserve additional testing to see what could be optimized. So even though imaging like an ultrasound can miss endometriosis, you still want to run imaging tests to help rule out other causes. So ask for a transvaginal ultrasound, ask for a blood test that shows estradiol, progesterone, and also inflammatory markers like C-reactive protein. Ask for a CA-125. It's a nonspecific test, but it can sometimes be elevated in endometriosis. Based on your labs, you might need natural progesterone to try to balance your hormones. If your estrogen is high, you might need additional supplements to address it, or a shot like Lupron. You may need to change your diet. I was taught at Harvard that you want to suppress your estrogen level, your estradiol, down less than 30 in women with endometriosis, starting with supplements such as diindolylmethane, calcium diglucarate, myomin, omega-3 fatty acids, or resveratrol. So the pro tip here with endometriosis is that if you're repeatedly dismissed, bring a written summary of your symptoms and a brief literature reference, like the one in the show notes, which is Zondervan et al., New England Journal of Medicine, 2020. Use that to advocate for a proper workout. You use that to advocate for a proper workup. You deserve it. Number 3 is Hashimoto's. This is the thyroid trap. This is where you're exhausted, you're gaining weight, you're losing hair, and your doctor says, but your TSH is 3.2. That's normal. So if that sounds familiar, it could be Hashimoto's thyroiditis, which is the most common autoimmune thyroid condition and the most under-tested because it mostly occurs in women. Symptoms often show up for years before the labs start to show. Symptoms can go on for years before labs start to show a change. Symptoms include fatigue, cold intolerance, constipation, dry skin, thinning hair, especially the outer third of the eyebrows and your eyelashes, brain fog, irregular or heavy periods, and mood symptoms. And here's what's missed: elevated anti-thyroid peroxidase antibodies, anti-thyroglobulin antibodies, a low free T3, a high reverse T3, subclinical hypothyroidism, which is often dismissed. We've got a separate podcast where we go deep on the thyroid, and I'd recommend that if you want to go further. So what do you do if you're dismissed and you suspect Hashimoto's? Number 1, ask for a full thyroid panel. Don't settle for a TSH alone. Request a free T4, a free T3, anti-TPO and anti-thyroglobulin antibodies, and reverse T3 if you're fatigued, stressed, or not responding to thyroid medication. Number 2, track your symptoms over time. Use a tracker or journal to monitor your energy, your cycle patterns, mood, bowel movements, temperature sensitivity, and hair changes. Bring it to every appointment. Clinical patterns often appear before the labs change. And then number 3, find a provider who understands autoimmunity and functional thyroid care. You might need a second opinion from an integrative, functional, or naturopathic doctor who understands subclinical hypothyroidism, the role of the conversion of T4 thyroid hormone to T3 thyroid hormone, and why TSH alone doesn't cut it, especially in women. So 90 to 95% of hypothyroidism is autoimmune in origin. If you don't test antibodies, you don't know if it's Hashimoto's. Number 4 is perimenopause. Many women are just told they're too young to be going through perimenopause. I hear all the time, you're only 39, you're only 43, you're too young for perimenopause. It is not true. Welcome to the dismissal and the gaslighting of perimenopause. What often gets misdiagnosed as anxiety, depression, premenstrual syndrome, or mood swings can actually be the first signs of hormonal transition. That includes insomnia, night sweats, anxiety, shorter cycles, brain fog, feeling like a different person every week of your cycle. And here's what most doctors miss. Number 1, progesterone starts declining in your mid-30s. Estrogen may spike and crash unpredictably for years before it starts falling. So you might get prescribed a selective serotonin reuptake inhibitor, an antidepressant, or birth control instead of bioidentical hormone support or even acknowledgement. If a woman in her mid-30s or 40s reports cycle changes, night sweats, insomnia, or anxiety, she's dismissed. But those are the hallmark perimenopausal symptoms, even with a normal set of labs, including estrogen levels or follicle-stimulating hormone, FSH. Progesterone starts to decline in your mid-30s, often 5 to 10 years before your final menstrual period or menopause. And here's what's happening biochemically. Perimenopause can last 5, 10, 15, even 20 years, as in my case. In the first half of perimenopause, there's declining progesterone, and that can be combined with fluctuating estrogen, sometimes wildly fluctuating. In the second half of perimenopause, that's when you have a decline in estrogen. So we're going to dive deep into perimenopause and menopause in a separate podcast, but definitely this is a common misdiagnosis, and it's one of the reasons why so many women are prescribed an antidepressant or a sleeping pill. So what do you do if you're dismissed and you suspect perimenopause? Number 1, track your symptoms by cycle phase. Start noting your mood, sleep, energy, cravings, temperature shifts by the day of your menstrual cycle. Tools like a simple calendar can work great. We're looking for patterns that show up before hormones start to change beyond the lab reference range. Number 2, ask for targeted lab testing. So perimenopause is largely a clinical diagnosis. It's based on symptoms, but testing your progesterone on day 21 or your estrogen and FSH on day 3 of your menstrual cycle can provide context. Request a Dutch test or a vibrant hormone zoomer if you want deeper insight into estrogen metabolism and cortisol. You might also benefit from measuring anti-Mullerian hormone or AMH. And then number 3, find a provider who treats perimenopause. Most doctors are not trained to treat perimenopause or to even act when FSH is still in the normal range. So you want someone who understands progesterone deficiency, estrogen fluctuations, and how to treat the whole person, not just the labs. So if you're dismissed with, it's just stress, mention that 73 to 75% of women who have perimenopause are not getting the treatment they deserve, and that has to change. If any of what we covered today sounds like your story, you're not imagining it, and you're certainly not overreacting. You're not fine. You've been overlooked. You haven't been heard, and it's time that that changes. These are not rare diseases. These are common, treatable, and often totally missed conditions that women experience. At Treated with Dr. Sara, we don't accept normal when you feel anything but. It's time to stop pathologizing women's bodies and start trusting our symptoms. Let's face it, conventional medicine has a blind spot the size of a uterus. There's an alternative. Here at Treated, we investigate, we validate, we connect mood to molecules, and we stop waiting for you to hit rock bottom to get answers. We love labs. We love the hypothalamic pituitary ovarian axis. We love a good PubMed deep dive, but mostly we love restoring your faith in your body and trusting your intuition. You don't need to be trying to get pregnant in order to get a full hormone panel. We all need a better standard of care. Because when a woman knows what's happening in her body, she becomes unstoppable. And it starts here.
Hey, Dr. Sara. I recently underwent a few weeks ago an abdominal hysterectomy and a right oophorectomy. So I had my tubes, my right ovary, and my uterus removed. I'm 42. I had a large fibroid and then a large benign tumor on my right ovary. So I basically just have my left ovary left. I tried to ask my OB-GYN about things that I can do, hormone therapy. And he did tell me, come back when you think you're in menopause. And I just feel like that's not really helpful. I want to do what I can to support my health and my body through this. And I've read your book, The Hormone Cure, and I'm just a big fan and would really love any sort of guidance on women that have undergone a hysterectomy or an oophorectomy and still do have one ovary left, what we can do to support ourselves through this whole kind of change. Because I just don't feel like myself, and I just want to do what I can to support my hormones and my body and my mind and all that. So suggestions would be greatly appreciated. And thank you so much for all you do.
I'm really touched by this listener. I also went through a hysterectomy before menopause, and I want to say a couple of things about what happens. So first, I want to just validate and honor that this beloved listener doesn't feel like herself after a hysterectomy. And a lot of women experience this. So what we know is that when you take out the uterus and the tubes and one ovary, the blood supply that goes to that remaining ovary, in this case, the left ovary, is compromised. It's not what it was before you had the hysterectomy. And so when the blood supply is compromised to your remaining ovary, it's not like everything goes back to normal. You're in this limbo state between how you felt before the surgery and menopause. The other thing about the limbo state is that you don't have a menstrual cycle to guide you. And so you have less information compared to someone who doesn't have a hysterectomy. And that's where labs can be so helpful. So my first recommendation is that you go back to your doctor. Let's give him one more chance. Go back to your doctor and say, okay, I'm not just going to wait until I'm having hot flashes and my personality is completely changed. Why don't we run some labs? And here's what I'd like to look at. I want to look at my estradiol level. I want to look at my follicle stimulating level, FSH. We'll talk more about this in a podcast on perimenopause and menopause. I want to check my anti-Mullerian hormone so that I can predict when I'm going to go through menopause, or maybe I'm there already. So I would say do some laboratory testing. And then you've read my book, The Hormone Cure. Thank you so much for that. There's some lifestyle things that I think are really critical. So we know that when you're in this limbo, and I would officially say you're in perimenopause, we know that lifestyle medicine becomes so important. That includes getting the right nutrition, making sure you're getting adequate, healthy fat, making sure you're getting sufficient protein to build your muscles because they start to decline after 40. And my love, you are at 42, so very important for you. On average, women lose 5 pounds of muscle every decade after 40 and gain about 5 pounds of fat every decade after 40. So we want to mitigate that with resistance training, with regular exercise, with zone 2 training, and even with VO2 max training, a topic for another time. So I would say those are the things to do first. Don't accept this idea that you should come back when you're in menopause. No, let's manage it proactively and check these hormones: estrogen, FSH, anti-Mullerian hormone, Start there, and then let us know how you're doing. Thank you so much for your question. You just heard of a very common condition, which is a woman who's had a hysterectomy, and you lose that clue about what's going on with your menstrual cycle. That's the situation where laboratory testing becomes so much more important. So it used to be that hysterectomy was the number one surgery that women underwent. Fortunately, that's no longer the case, but many of us do go through a hysterectomy. And I would say that's when we especially want to rely on a combination of the symptoms that we're experiencing, including the more subtle 100 plus symptoms of perimenopause, together with laboratory testing. So in all women, whether you've had a hysterectomy or not, you want to be paying attention to symptoms together with laboratory testing. Thank you so much for listening. If you have a question or a comment, please go to speakpipe.com/treated. Thank you again.